At this time, I would like to introduce you to our speaker, Chris Tilden. Chris has spent most of his career in health and social services. For 10 years, he served at the Kansas Department of Health and Environment, where he was the Bureau Director of Local and Rural Health. He also has held positions in Ohio and Idaho. He joined the Lawrence Douglas County Health Department in fall 2012. As a longtime resident of Lawrence and Douglas County, he is excited to have the opportunity to contribute to the vitality of the local community. Now I'll turn it over to Chris.
Hi, Kim, can you hear me?
Yes.
Okay, great. Good morning, good afternoon, depending upon where you are. I'm really pleased to be part of the discussion today about ways that public health and the healthcare system can collaborate to improve public health and to improve population health. I'd like to thank Kim and the National Rural Health Resource Center, as well as the Office of Rural Health Policy, for providing me this opportunity. I have long been affiliated with the center as well as the Office of Rural Health Policy. I see a number of familiar names on the webinar today. I do hope that this is not a one and done, but is part of an ongoing dialogue about how we can improve collaboration between public health and healthcare systems across the country as a vehicle to improve community health. I know that a number of you may be familiar with me, but I thought it would be helpful for those of you who do not to know a little bit about my background. As Kim mentioned, I'm currently the Director of Community Health at the Lawrence Douglas County Health Department, which is in Lawrence, Kansas. I have been here in this role for a little over 5 years now. So I've had an interesting transition in the sense that I began my career very much at kind of the national level, continued to work on federal issues, but also state, ultimately moving to a role that was both a little bit state, regional, and local, and now moving into a position at the local level. So some of my past roles, I worked at Mountain States Group as Executive Director. That's an organization based out of Boise, Idaho, from 2010 to 2012. And there were programs at Mountain States Group that served both local, state, as well as at a national level. And one of the roles I was fortunate enough to have the opportunity to work in while at Mountain States Group was serving as the project director for the Mississippi Delta Rural Hospital Improvement Program. Before joining Mountain States Group, I was at the Kansas State Department of Health and Environment. And Kim, seem like I've lost control of the slides, but are you restarting?
I'm restarting, yes. Sorry about that.
Okay, all right, not a problem. I was the director, as Kim mentioned, of the Bureau of Local and Rural Health at KDHE for about 8 years. I actually joined KDHE initially in 2000 as the director of the Office of Rural Health. I just noticed a typo there in that I served as that director for about 2 years and then was promoted to the director of the Bureau, which oversaw not only the Rural Health Office but also the Primary Care Office, the State Trauma Program, the Migrant and Farm Worker Health Program, and some others, and had several individuals that then served in the capacity of the director of the Office of Rural Health while I was there. And I was delighted to see Gloria Vermees' name on the attendees today. She was one of those fantastic directors of the Office of Rural Health during my tenure at KDHE. Before that, I served as president of a group called Medical Search Institute, which worked principally on issues around medical staff development planning, as well as physician recruitment and retention. And in the 5 years and was in that role, worked with small rural hospitals in over 40 states around the country. So I definitely have gone from a very national perspective to my role here at the Lawrence Douglas County Health Department in a kind of an uber local kind of way. So let me also tell you a little bit about my current role and about Douglas County, if you're not familiar with it. Douglas County is located in the northeast part of the state of Kansas. We have a population here of about 110,000 people. Lawrence, the county seat, represents kind of the bulk of the population of Douglas County with about 87,000 residents. The remainder of the county is relatively rural with 3 small communities, Eudora of about 6,000 people, Baldwin City, 4,500 residents, and then a small town of Lecompton with 500, and the remaining 12,000 or so in our population residing in the unincorporated areas of the county. The health department itself is a bit of a unique health department in that we are one of just several city-county health departments. So we are financed by both the City of Lawrence as well as Douglas County. We do have a freestanding health board. So we have a health board of 9 representatives, of which 4 are selected by the city, 4 by the county, and then we actually have an ex officio appointment from the University of Kansas because we do have the University of Kansas here in Lawrence, very large university with close to 30,000 students on campus. And in fact, Douglas County is a little unique in that we have 4 institutions of higher learning, not only Kansas University, but also Haskell Nations Indian University, Baker University, which is a small private college, and Peasley Technical Institute, which is a community and technical college. So we have those 4 institutions. We are, from a standpoint of ethnic and racial diversity, a fairly homogeneous county with a population of, our white population is roughly 9 out of 10 residents in the community with smaller populations than of African American, Hispanic, Native American. We are a little unique in that with Haskell Nations Indian University here in the county, we have about 4% of our population who are Native American, which is higher than the national average, and a very diverse representation of Native Americans, given that there are generally, at any one point in time, about 200 different tribes represented by the students at Haskell University alone. So we are fairly unique in that perspective. We're what I would consider a medium-sized health department of about 40 staff. I think our community health program is certainly a little unique in that we are fortunate to have 6 staff. So in addition to myself, we have a planner, 2 analysts, and 2 community liaisons, and I'll describe a little bit more about their roles as we go through the webinar. I recognize that is, you know, we're in a metropolitan area, so when I say a medium-sized health department of 40, I know in comparison to most smaller rural health departments, we're pretty generously staffed. So I will talk a little bit about the experiences here, but certainly want to have discussion about how those experiences translate into rural environments or areas where, you know, the rural perspective certainly might be unique or different to what we experience here in Douglas County. So as we get into this discussion of population health, I think it's important that we're all on the same page in terms of what how we would define population health. And certainly at the highest level, population health is the overall health outcomes of a population. And importantly, I think not only the overall health outcomes, but also understanding the differences or the disparities within that population, as well as the root causes of those disparities. And I just as an example threw up a map of Douglas County, which I know is probably very difficult to read, but I wanted to make a point here about disparities, and that is that even here in Douglas County, with a relatively homogeneous population compared to a lot of areas around the country, we certainly experience disparities. And what this map represents is life expectancy, and the area in yellow is this is a census tract level map, so all census tracts in yellow have an average life expectancy that is no different than the county average. And our county average life expectancy is about 80 years. If you look in the lower left quadrant, however, we have a very large census tract. That's one census tract. Very small population in that census tract. None of our municipalities lie within that area in the southwest part of the county. But that area has a life expectancy that on average is about 4 years greater than the county average. And the area up in the kind of the north central part of the county, represented in orange, actually has a life expectancy that is about 4 years less than the county average. So I'll speak more to disparities as we move forward, but wanted to point out that a lot of our work has been focused on trying to better understand the root causes of the differences that we see among the different populations in our community. I do want to talk a little bit about the evolution of public health, because when I, in the earlier slide, talked about a community health program with 6 staff, that was a program that started with 1 staff 5 short years ago, and we've seen a real progression and a real evolution here locally. And I think that evolution in some ways reflects what is happening at a national level. So I've kind of defined public health through 3 stages. And if you look at most of the 20th century, as you all know, there were significant improvements and enhancements in the health of our nation that were largely the result of systematized efforts to improve sanitation, to improve water and food safety, to develop prevention and treatment tools like vaccinations and antibiotics, and greatly improved lab services. The focus during the 20th century largely was on environmental health issues and infectious disease. I think as we near the end of the 20th century that there were also other roles that the public health that public health began to take on as well, one of those being increased responsibility as a safety net provider for some clinical services. And also during that time, I think a growing recognition of changing drivers of what keeps us, what makes us healthy. And now I'd argue that we're beginning kind of a 3rd stage in the evolution of public health, which really looks at how can public health, as part of a larger public health system, create collaboration among multiple partners, including the healthcare system, business, education, government, and others, to better understand and address community health determinants. And I recognize that certainly this is just the beginning of a change in our industry as a whole, and that I would say there are, at this point in time, really pioneering communities that are further along in utilizing this approach to address the health of their community. In the last slide I said I ought to give some additional credit, I think, to this concept of Public Health 3.0, because there really is a national dialogue. If you Google Public Health 3.0, you'll find a series of documents about the changing nature of public health. That dialogue has been led primarily by Dr. Karen DeSalvo, who is a former health officer for the City of New Orleans, also the National Coordinator for Health Information Technology, and in her role as Assistant U.S. Secretary for Health in the Department of Health and Human Services, kind of began this discussion at a national level about the evolution of public health to this 3.0 stage. In addition to the discussion led by Dr. DeSalvo around Public Health 3.0, one of the other drivers and one of the initial questions was about understanding of public health and their requirements for community health needs assessment. Those requirements for public health participation in community health needs assessment really is defined most specifically by the Public Health Accreditation Board, or FAB. And I hope that some of you are familiar with FAB, and if not, I'll certainly talk a little bit about FAB and its evolution. But FAB was launched in 2011, so it's a relatively recent phenomenon. And it is a system that measures performance against the 10 essential public health services. So if you look at the wheel on the right-hand side, is a graphic of those essential public health services. You know, public health at its core really focuses on assessment, which is a function of monitoring health and diagnosing and investigating disease. With that evidence base in hand, developing policy, so informing and educating and empowering the community, mobilizing the partnerships that I think are at the core of our discussion today, and then using the power of those partnerships to develop plans and policies, and then assurance, looking at how are we doing? Is that policy development having the intended changes that we would like to see through the enforcement of those policies, ensuring that there are adequate linkages in the healthcare system as well as in public health, and assuring a competent workforce. So this public health accreditation process is at all levels, state as well as territorial and tribal and local. And while it is relatively new, as you can see, its impact has grown pretty phenomenally and quickly, to the extent that about 80% of the U.S. population technically is covered by a health department that is accredited by FAB. Those 220 health departments include over 30 state health departments, close to 200 local health departments, and one tribal health department. So I'm going to talk specifically to some of the requirements for community health assessment and planning, because I do know that that is also a requirement of nonprofit hospitals, and is certainly a key entry point, I think, for a discussion about collaboration around population health. So my first slide here on community health assessment focuses on some opportunities for collaboration within the context of community health assessment, or I think in the hospital vernacular usually is community health needs assessment. I'm just going to read through this first domain about assessment because it is kind of the fundamental requirement of FAB, is that public health departments do conduct and disseminate assessments that focus on population health status and public health issues that face the community. And there are 4 standards that make up the domain. One is to participate in or conduct a collaborative process that results in a comprehensive community health assessment. There's also a requirement for an annual update of that assessment document. Standard 1.2 is about collecting and maintaining reliable, comparable, valid data that provide information on the conditions of public health importance. So that's certainly part and parcel of Standard 1, but somewhat broader. Standard 1.3 is about identifying trends in health problems, but also identifying not only those trends, but what are the social and economic factors that really have the greatest impact on public health. And I'll speak quite a bit to that as we move on into additional slides. And also then use that information to use those results of those analyses to develop recommendations regarding public health policy, processes, programs, or interventions. So here I just wanted to provide a few examples of the type of information that we developed as part of our most recent community health assessment, which we just published in 2017. And that is not to say that this is data that you're necessarily going to find in any given community health assessment. I think they can differ significantly from community to community. But we were fortunate last year to be able, for instance, to do an analysis of the deaths in Douglas County. We looked over a 6-year time frame in order to establish a meaningful enough sample size. That's represented by the pie chart on the right. Just one quick kind of tangential or side note, and that is if you look at the pie chart, the conditions that primarily are leading to death in Douglas County, and this is very consistent to what you see in other communities across the country, are chronic disease, things like cancer and heart disease, which collectively contribute to more than 4 out of every 10 deaths, as well as other chronic diseases. In Douglas County, unintentional injury is on that list in the 4th leading cause of death. That has changed dramatically here in recent years. I mean, if you look at unintentional injury, I think it's been a contributor to causes of death, but the kinds of deaths in that category have changed pretty significantly. Historically, that was really highly populated by motor vehicle crashes. Those have been dropping precipitously in Douglas County, as has been true across the country, although rates still tend to be higher in rural communities. But it really is both falls and poisonings due to use of not only opioids, but other drugs. But in Douglas County, as in other places around the country, we are beginning to see certainly an uptick in opioid-related deaths. And then suicide is also on that list, and that has been increasing as well here as in many other communities. So leading causes of death, I think, was something that really got a lot of attention and led to a lot of positive dialogue. We were able to use those same death data to develop life expectancy, which is the chart in the lower left-hand corner. And then we looked at some of the kind of prevalence data that are also quite common, things like fair or poor perceived health status, as well as actual health status indicators like cholesterol, hypertension, obesity, disability. And I'll speak to some of the sources of data as we go through the process, but I just wanted to provide some examples of some of the types of information about health status, which is that domain 1.2 for FAB that we used in our process. Domain 1.3 focuses on something I mentioned early on, and that is what are those environmental, social, and economic factors that really drive the health of our community. And I think the graph on the left, which most of you are probably familiar with, is an important one. I've seen several iterations of this, but this document or this diagram comes from the Community Health Rankings, which is a county level health ranking that you probably are also familiar with. It comes out each spring. and it emphasizes that it's really social and economic factors and health behaviors that drive about 80% of our health. And I would argue that the social and economic factors, that 40%, may be a little underestimated, because what we know at the end of the day is that health behaviors, while in part are based on individual choice, where you live, the kind of job you have, the environment, both the built environment and the natural environment in which you live, very much has important impacts on health behavior. So that social and economic factors is really, really key. And I just want to highlight quickly some sources of data, because I know that not every health department or every local hospital is going to be able to do the kind of analysis that we might be capable of with two analysts on our staff here. But for instance, if you're not familiar with county health rankings, again, that's a county level analysis that's done on a year-to-year basis that ranks counties within states and across the country. So you can pull up state level or county level reports at county health rankings. I'd encourage you to take a look if you're not familiar with that. The Behavioral Risk Factor Surveillance Survey. When earlier I provided some examples of statistics like obesity, cholesterol, disability. Each state participates in the Behavioral Risk Factor Surveillance Survey and have self-reported data for a variety of health behaviors, health outcomes, and drivers of health. And that's going to vary from state to state in terms of what's available. I know that in Kansas, the State Department of Health and Environment not only produces a state-level report, but provides some county-level statistics, and certainly has been a valuable partner in providing us with an awful lot of information. So while that varies from state to state, if you're not familiar with that survey, I'd very much encourage you to talk with your local or your state health department, because there's some fantastic data available there. Vital statistics at the state, I mentioned our use of death data, birth data are also generally available through the state, so those are a great source of information. At a national level, Community Commons is another web-based tool that has a tremendous amount of information, as does the HRSA data portal. I would recommend that you all take a look at those web resources. All of those provide really vital, what I would call secondary data that can contribute to your health needs assessment. But the last point I want to make on the slide is please don't forget to ask your community. The community's perspective on these issues is really of vital importance. And I'll speak to a few methodologies that we used as we developed our assessment in 2012, although there are many, many others that can be used. One of the tools that we used was a relatively simple, what we called a health issues survey, but the KU Center for Community Health and Development that we work through generally refers to that as a concern survey. And this is a survey that, rather than asking about individual health status, asks people about their perceptions of health in the community. Ask them about the issues that they feel most impact health in the community, and then I'll also ask, relative to those measures, how well do you feel our community is doing in addressing those? So we have a sense of what are the issues the community is concerned about, and does the community think we're doing a good job, or do they think there is room for improvement? We also used a series of public input forums that I can speak more to. Observation studies can also be useful. We had quite a bit of concern raised by our local community about the speed of traffic and the challenges that created in people walking and biking to work and or to school. And so we set up some really simple observations where we actually looked at driver yielding behavior around our schools and found, in fact, the community had a valid concern. We had a relatively high rate of individuals not yielding to school kids in those crossings around our school. We also collaborated with an area arts organization. They actually employ young people ages 14 to 20 and use that as a tool to help those individuals prepare for college and for careers through an arts-based program. And so we utilized that institution, Van Gogh Arts, and had them develop a photo voice project where these young people went out into the community and captured through film the issues they feel impact the health of our community. A couple of the pictures in my introductory slide, my title slide, came from the photo voice work of those youth. So it was a tremendous experience with several hundred photos collected from those youth who then went through a collaborative process where they got together and talked about what themes emerged as you looked at the community through the lens of the camera, and came up with a set of about 20 photos that we used as part of our community health assessment process. It's a great tool for not only getting a great visual sense of the health of your community, but engaging community in the process of data collection itself. So I'm going to transition a little here, and if you recall when we were talking about community health assessment and the FAB standards, that fourth standard, standard 1.4, was about how we use data to inform policy. And that kind of then slides into a discussion of the fifth domain in the FAB accreditation standards, and that is really about developing public health policies and plans. And I'm going to focus on the first two standards there. One is the standard about serving as an expert resource for establishing and maintaining public health policies, practices, and capacity. I think there clearly is a role for public health, but also a collaborative role with practitioners who very often are seen as key expert resources in the community about those issues that impact public health and impact the population of a community. And one of those standards, the standard 5.2, is about the actual conduction of a comprehensive planning process to result in a community health improvement plan. And if I am not mistaken, in the same way that public health departments are required to do an assessment and then a plan, it's my understanding that that your hospitals also, after completing that community health needs assessment, are required to look at that data and think about what are action steps that could be taken. How can we plan to actually address issues that are impacting the health of our community? So that is an important concept, and one where we're kind of right in the thick of that process of developing our new plan. It's interesting, FAB is on a little bit different cycle in that it's a 5-year accreditation process. So the actual requirement of FAB is a 5-year versus the nonprofit hospital 3-year cycle. And I'd love to know how your various communities might be dealing with that discrepancy. But I'll talk a little bit about our community health improvement planning process in hopes that it might provide some insight or ideas for all of you as you participate in those efforts locally. In Douglas County, we really wanted this to be a county plan, not seen as the plan of the health department. And so when we began that process over a year ago, what we chose to do was to actually seek formal representation from all of the formal jurisdictions in the county So we went before the county government and also each of the municipalities and asked for representation. So in all cases, there's either an elected official or a senior staff person and perhaps other members of the public that they felt would represent local issues. But we've got the 5 jurisdictions in Douglas County. Each of them were represented in the process. We pulled together that group and then asked, who else do we need to bring to the table in order to have broad representation across the community? So we brought in healthcare and business and education and law enforcement and social services. There's one audience I think that I left off of this slide, and that really are those populations that are actually most impacted by disparities. So in addition to this multi-sector representation, one thing we have wanted to address, knowing that disparities are a really important part of our public health picture, is finding ways to ensure that representatives of the populations that face disparities are represented in our process. The way we've been doing that with our recent planning process has been to work with a local agency called the Sunrise Project. They have long been an agency with a perspective, a focus on social justice, primarily through food. They manage several local community gardens. They have a youth program that focuses on kind of skill development through gardening, through cooking. They work with educators, both early childhood and in the school district, to develop farm-to-school programs. So really using food as a tool for promoting social justice. And we were actually able to secure some grant funding and contract with the Sunrise Foundation, who brought on a number of people from the community who we've been using for a couple of different purposes. One, we've been asking them to go out and have conversations with people in the community about things that they feel impact their health, and then bring that information back to the steering committee to provide that community perspective. So we actually have 4 individuals that all of whom are racial and ethnic minorities, people of low income, that really have provided, I think, a really valuable perspective in that work as we go forward. So we're really trying to look at how we engage in a meaningful way, understanding the needs of the community and trying to bring the impacted voices to the table. I know you probably can't read a word on this slide because of the size, but I put this up here only because this is a list of our steering committee members. And what I wanted to emphasize here was not so much who participated, but just the sheer number. I recognize this is a very large steering committee. We've had multiple conversations about both the need to be efficient and effective in our work, but also to have broad representation across the community. And as you can see, I think we really have erred on the side of ensuring that we have broad representation to ensure that we can develop a plan where we have shared accountability across the variety of sectors that comprise the makeup of our community. And as we go forward, sharing collective accountability for carrying out this work. So I think that broad-based process, while challenging, I think really has been important to our work. We felt it was less important to expedite the process, but more about creating shared interest and accountability so that we can establish shared goals and establish shared accountability for the results that we intend to monitor as we actually implement this plan following its development. Just real quickly, I would like to share some of the issues that have been identified in our process, because I think these are probably issues that that will resonate with many of you in your community. And certainly access to healthcare services was one of those issues that was identified. But many of these I would characterize as those more upstream social and environmental issues, access to safe and affordable housing, the use and misuse of alcohol, tobacco, and drugs, child abuse and neglect, discrimination. I'll talk a little bit about that in the next couple of slides. Access to healthy food and food insecurity, mental and behavioral health, physical activity, poverty, and good paying jobs. Those were the 9 issues that were initially identified by the steering committee. All of that data that I talked about earlier, we literally shared that with the steering committee over almost a 6-month process. So we did not in any way, shape, or form rush to judgment about what these issues were. We scheduled a series of meetings. We took time to talk about the issues survey that we administered to people in our community. We sat down to talk about the vital statistics and the other secondary information that were developed and collected. We had the youth talk about their findings from Photo Voice. We went through a very deliberative process of sharing that information and then working with the steering committee to create this narrowed list of 8. And then from this 8, we then went through a further kind of narrowing process to develop a final set of objectives for the community health planning process. So this is the same list of 8. You'll see that there are numeric scores on the right-hand side. These scores were part of a second phase of data analysis, and specifically in this case an organizational assessment. So we developed a tool. It was a survey to area organizations and businesses. I think it was sent to about 100 businesses in the community. Very simple tool saying, here are 9 issues that were identified as impacting health through the community health assessment process. And we'd like to know both, are these things your organizations are working on? And also, is there an interest level in participating in a collaborative discussion in the community? So these numbers, the 29, 24, 19, we had about 50 responses, and these numbers represent the number of organizations that on a Likert scale from 1 to 5, with 1 being not very interested to 5 being very interested, those organizations that said, yes, we're quite interested, we're a 4 or 5, we would like to be involved in a community discussion about child abuse and neglect or poverty and good paying jobs. So this was one of the secondary tools that we used to look at, okay, what are the issues that are the organizations in our community seem to want to focus on in the coming years. We also had a series of public health community forums and went through a very similar process of asking people about which of these issues did they believe had the greatest impact on health. And answers are similar, but certainly the area of focus somewhat different. It's pretty easy to quickly note that mental health and poverty and good paying jobs were kind of heads and shoulders above the other factors that were part of that process. So from all of that input, we went back to the steering committee and decided to focus on a smaller set of issues, those being behavioral health, which would include not only crisis intervention and recovery, but also prevention, poverty and jobs, safe and affordable housing, and healthy food and physical activity. I think most of these we would characterize as more upstream social and economic issues, which is, I think, what our community really recognized they needed to focus on. And one of the things, I didn't provide much data, but again, speaking to disparities, a significant amount of our disparities, we were able to look at differences among education levels, among income, race and ethnicity. Because we're a relatively small county with relatively small sample size, it was somewhat difficult to have a representative sample so that you can even do that kind of disparity work. But at the end of the day, for almost any indicator, whether it was related to access, like affordability of health care, access to insurance, or if it was about healthy behaviors like tobacco use or physical activity or diet, or if it was related to health outcomes, the existence of mental and or physical conditions. In almost every case, we were able to document financial disparities with low-income populations having poorer health outcomes than higher income folks. So I say that because as we looked at the data, our steering committee also felt while these 4 areas of focus were appropriate, there really needed to be an overarching theme of discrimination and equity. And that's, again, where these coordinators that were hired by the Sunrise Project, I think, will really be helpful as we develop our plan. We will have people impacted by disparities who will be helping lead that process. We're now at the step where what we're doing is identifying leaders around each of those groups to put together work groups, including impacted residents. So our behavioral health group will be headed up by a coordinator for behavioral health at the county. The poverty and jobs group here will be headed up by the director of our local United Way. The safe and affordable housing group is going to be headed up by the executive director of the local housing authority, and healthy food and physical activity will be headed up by a coalition we have in the community called Live Well, which focuses primarily on healthy food, physical activity, and tobacco. So as you can see, the role of public health in this process is really one of convener and one of facilitator and support. But the process itself is really being led by members of our community. So with that, I know that I've gone on for about 45 minutes. I just want to kind of reiterate some of the key points that I hope I've been able to make today, and that is certainly public health is evolving, and our focus is becoming more and more on collaboration with healthcare and other key partners in our community to affect policy, system, and environment change. The work of community health assessment and planning really is at the heart of our public health mission. And in fact, we have pretty strict requirements for accreditation about what those processes will look like. So for the community health assessment, we have to identify a multi-sector process, that we've used mixed methods, a number of different methods to come up with our conclusions, and that we've engaged the community at large in the process. And with the community health planning process, again, we have to demonstrate broad stakeholder engagement, that we've used the community health assessment data to identify themes and issues, as well as community assets, that we've identified priority issues, and that we've developed measurable objective strategies and performance measures. I mentioned a number of sources of data, but I probably just scratched the tip of the iceberg. And ultimately, I think, what I hope the message is that it's important that all of us, whether we're in healthcare, public health, or other members of the community, that we begin to look at how we can collaboratively address the upstream root causes or the social determinants of health, because ultimately I think that's the way that we most effectively are going to be able to impact health outcomes and the cost of intervention associated with those poor health outcomes. So with that, I'm going to pause, take a breath, turn it back over to Kim. If there are questions, comments, I'd love to field those. So thanks again for providing me with the opportunity to participate and talk with you today.
Chris, thank you so much for that presentation. You offered some really great secondary tools and ways to engage the community and the youth and the people most impacted by those social determinants of health. Very interesting. If anyone has any questions, you can press *2 to unmute your phone line, or you can type something into the chat box. And before you log off today, if you could complete those 2 poll questions, that would be excellent. Well, I don't think anyone has any questions right now, Chris, but if you think of a question after this webinar, you can certainly contact me, or Chris's information is in the PowerPoint slides.
Yeah, feel free to, my email address is on the title slide. You know, if you have any questions about tools or methodology, you know, feel free to reach out to me. You know, a lot of these tools sound complex. You know, at the end of the day, I think there are simple ways to administer a lot of the tools, or at least a lot of the ideas we've talked about. I also mentioned the presence of a number of local universities, and I'd be remiss in not saying that we do work very closely with the KU Center for Community Health and Development, who provides some tremendous support for some of our work. And for those of you who have local university resources at your disposal, that is another one that I would just encourage you to think about, because I'm not sure we'd be able to do the kind of work that we've done here, even with 2 analysts on my staff, without having a university that's really committed to being part of the process and providing with some amazing support. So please feel free to reach out to me at my email. All of the reports that I talked about and descriptions of the tools are also at our website, which is just www.ldchealth.org, as in my email address. So I'd love to hear from you and love to talk to you more about your efforts in this area.
All right, great. Thank you so much, Chris. The recording of this webinar, along with the slides, will be available on our Help Webinar Playbacks page later this week. And before you log off, if you could please complete the short online assessment for this webinar using the links on the screen. You can also register for any upcoming webinars or access our large array of resources, including the Rural Hospital Toolkit for Transitioning to Value-Based Systems and the Population Health Portal.